Now coming to the anatomy. So under what headings usually the question will be asked? We should know the anatomical features of kidney. We should know position, extent, relations, hilum, peritoneal coverings. We should know the internal structure, cortex, medulla, the vascular segments of the kidney, blood supply, lymphatics, and also applied anatomy. So coming to the features like kidney, like we have a pair of bean-shaped organs which are located in the posterior abdominal wall. So what are the muscles we are finding? We are finding psoas major, we are finding iliacus. Okay, psoas major, iliacus. These are the muscles we see in the posterior abdominal wall. So this upper part is actually diaphragm. We are finding spleen is intact here. Okay, this is abdominal aorta. This is inferior vena cava, right? So these organ are situated retroperitoneally, that means behind peritoneum. So each kidney, it has two surfaces. In the front it has anterior surface, and behind it has posterior surface. Then it has two ends like upper end, lower end. It has medial border, then it has lateral border. So long axis of kidney is directed downwards. Okay, then extent is, it is extending from T12 to L3. Okay, then so the kidney, left kidney, suppose this is right kidney and this is left kidney, and if you observe both these, left kidney is nearer to the midline and to the diaphragm than the right kidney. So medial border is concave, and this medial border is actually called as hilum, because we will see the structures are entering and coming out at this area, hilum. When you see the dimensions, the length is 12 centimeters, width is 6 centimeters, and thickness is 3 centimeters. Okay, and in the hilum we have three structures, van structures. Anterior to posterior we have portal, renal vein, renal artery, and the pelvis which continues as ureter. Okay, then so the long axis of the kidney is directed downwards and laterally, so that upper end is nearer to the vertebral column than the lower end. Okay, so that means it is something like this. Upper end, it is little oblique. So upper end is coming more close to the vertebral column than the lower end. So this is the transverse axis. If you remember me telling transpyloric plane, it is the plane which passes, it is cutting the hilum of right kidney and to the lower part of the hilum of the left kidney. Upper part of the hilum of right kidney and lower part of the hilum of the left kidney. Right kidney is situated little lower in position than left kidney, because on right side we have liver, which is quite big bulky organ. Left side we have only stomach, isn't it? So what are the factors which keep kidney in position? All neighboring visceral organs, they exert pressure so that it is not slipping down. Okay, also we will have fascia and fat which is holding it in place, and also the hilar structures which also uh, keep this kidney in position. Okay, now the kidneys like extent, you can see it is lying at the level of T12 to L3. Okay, right kidney is slightly lower than left kidney because on right side we have liver. Okay, dimensions I told you. So hilum, we have these van structures like renal vein, renal artery, and we have ureter. Okay, so this the upper part of the ureter is actually called as renal pelvis, the starting point. Okay, now coverings of kidney itself may come as 5 marks question. Okay, this you need to pay little attention. So we have certain coverings over the kidney. So what are those? First thing we have is fibrous capsule, the capsule which is being stripped off from the kidney and has been shown. So that capsule which is surrounding the kidney, immediately you call it as fibrous capsule. It is closely applied to the surface of kidney. Okay, so suppose this is the transverse section of the body wall which is taken at the level of L2, lumbar vertebra. Okay, we are finding one kidney here. This is left kidney. We are finding inferior vena cava, abdominal aorta. These are structures in the hilum of the kidney, renal artery, renal vein. You are finding there is one fascia covering the kidney. Okay, you call it as actually immediately covering this black line is actually the fibrous capsule. Surrounding this black line, some fat is there. You call this fat as perirenal fat, which is outside to the fibrous capsule. Okay. Above this perirenal fat also we have a fascia, that is the renal fascia. You can see this renal fascia is shown in like white line or light blue color line you are finding. So we have anterior layer of the renal fascia, we have posterior layer of the renal fascia. So anterior layer and posterior layer are fusing laterally and they become continuous and they form a single layer. Okay. So condensation of connective tissue which is seen outside to the perirenal fat is nothing but renal fascia. Now, surrounding this renal fascia outside again we have fat. If you can see or observe here again we have fat. You call this as pararenal fat. Okay, it lies external to the renal fascia. Okay, then so again now if you just observe like all these things I kept once again. Fibrous capsule is the one which is formed by the condensation of the fibrous stroma of the kidney. It can be easily stripped off if the kidney is healthy. But suppose if the kidney has some underlying disease, this capsule becomes adherent and it cannot be easily stripped off. Okay, then perirenal fat where arrow has been shown like between the fibrous capsule and the outside perirenal fascia you will see this fat. Okay, so third layer is perirenal fascia or renal fascia, where I told you anteriorly we have one layer, posteriorly we have one layer. Okay, laterally they are fusing and lateral continuation is called fascia transversalis. This one, this line, which this anterior layer has been given a special name called as fascia of Told. Posterior layer is given a special name called as fascia of Zucker-Candle. So anterior layer and posterior layer together, they are reflected laterally to form fascia transversalis. Okay. So this is all fascia transversalis which is traced laterally. Medially it is moving anteriorly to cover inferior vena cava abdominal aorta. Okay, and posteriorly it is going in front of psoas major muscle and the vertebra, lumbar vertebra. This is the posterior layer which goes like this. Okay. Mm, this may be a little confusing. I just don't want to confuse you. Now see, there was a question for 3 marks also, like what are the relations of the left kidney, right kidney, something like that. So this picture will help us to understand the anterior relations of right and left kidneys. So in front of the right kidney, we have the organs like suprarenal gland. This area is for liver, hepatic area. This area we have, it is occupied by duodenum, that is duodenal area. This area is for right colic flexure colon. This area is for jejunal coils. All this I told you, kidney is kept in position because all surrounding visceral organs are pressing and it keeping it in position. Similarly, this is left kidney. On the left kidney we have anterior relations like suprarenal area, we have gastric area, splenic area, pancreatic area, jejunal area and colic area. Okay, these are the anterior relations. Okay, and these are the peritoneal coverings. The peritoneum is present in front of the kidney. When any organ is present like behind the peritoneum, you call such organs as retroperitoneal organs. So the area which is covered by the liver and small intestines is covered by peritoneum. On the left side you will see area covered by the stomach and jejunum, they are covered by peritoneum. Okay, so anterior relations. Now, posterior relations. See, the left kidney is related to 11th and 12th rib. Here also you are finding 11th rib is not directly in contact. Right kidney, it is basically much in contact with 12th rib, because I said on right kidney is little lower because on the right side we have liver. Now on the posterior aspect, both the side we have same muscles. You remember this PQT code, PQT. So as major muscle we have, then we have quadratus lumborum, and then we have transversus abdominis. So as major, quadratus lumborum and transversus abdominis are the muscles what we see on the posterior aspect. Okay. Both the side you will see same relations. These three are important. Apart from that, you will see psoas major, quadratus lumborum, transversus abdominis. Relations of right and left kidney anteriorly were different, but relations, posterior relations are same. Okay, so left kidney, it's related to 11th and 12th ribs, diaphragm, costodiaphragmatic, pleural recess, subcostal nerve, iliohypogastric nerve, ilioinguinal nerve. Okay, same thing, only thing is on the right side we have only one rib, that is 12th rib, whereas on left side we have 11th and 12th ribs. Okay, so these are the nerves what you saw here, subcostal, hypogastric, ilioinguinal, they are shown here. They are actually coming as branches of lumbar plexus. This is subcostal nerve, this is iliohypogastric, and this is ilioinguinal nerves. Okay, so like that you have medial relations, we have hilum. So when you do like your viva, you have to check whether it is right or left kidney. How to identify? By looking at the structures in the hilum. The arrangement of structures in the hilum are anterior to posterior, those are VAP. VAP, that means in the anterior aspect we have renal vein, in the middle we have renal artery, and behind we have the pelvis which continues as ureter. Okay, VAP. Okay, then when you see the internal structure, the cut section of the kidney, the outer area is cortex and inner area is medulla. In the medulla region, we have these cut sections like triangles which are called as renal pyramids. Okay, then so in the renal pyramids, this is the base and this is the apex. Okay, and here all these lines, they are actually called as renal like calyces. We have major calyx, then we have all minor calyces will unite to form the major calyx. Major calyx will unite to form the pelvis continues as ureter. Okay, so renal pyramids have base and apex. Apex is moving towards minor calyx. Okay, then if you just observe the renal artery is going inside and it is branching. If you observe, it has interlobular artery, then it has arcuate artery, interlobar arteries. We will see the branching pattern of this also. Okay, basically the renal artery, we know it's a branch of abdominal aorta. So each renal artery, it gives 5 segmental arteries. You can see 1, 2, 3, 4 and 5 segmental arteries are actually coming as branches from the renal arteries. So 4 will be entering, 1, 2, 3, 4, they are entering from the front, and fifth one will be entering from behind, and in between the lobes it is moving, hence you call them as lobar arteries. These lobar arteries further they run between the renal pyramids, they are called as interlobar arteries. These are interlobar arteries. This is arcuate artery. When it arches, it is arcuate artery. Once it arches, it gives rise to afferent artery, glomerulus, efferent arteriole. Okay, see, the branching pattern is something like this. Renal artery, 5 segmental arteries, interlobar, arcuate, interlobular, afferent arterioles, glomerulus we have, right? Venous drainage will be in the reverse direction. We have renal venules, interlobular veins, arcuate veins, interlobar veins, then draining into renal vein. Okay? Then so this picture is also helping us to understand the blood supply. Okay, arteries from abdominal aorta, we have renal arteries, segmental arteries, 5 in number. These are interlobar arteries. And then we have arcuate artery, interlobular arteries. And venous drainage starts with interlobar vein, arcuate vein, draining into interlobar veins. Interlobar veins will drain into renal vein. Renal vein will go into inferior vena cava. Okay. So if you just see the blood supply, if the blood supply of kidney is asked exclusively, you have to talk about vascular segments. I told you we have 5 lobar arteries, 4 entering from front, 1 from behind, no? So they will supply in this way. So from the anterior aspect, 1, 2, 3, 4. One is apical segment we have. This is posterior segment. Then we have, actually we have antero-inferior, antero-superior and inferior. This labeling you can check. This is posterior segment. Okay. So what is this? Superior, inferior, antero-superior, antero-inferior and posterior. These are the 5 segments. This is the segmental type of blood supply. Lymphatic drainage of kidney, it is draining into lateral aortic group of lymph nodes. Okay, nerve supply comes from renal sympathetic plexus. Okay, so when you talk about kidney, always we will be bothered about renal stones, isn't it? So generally we palpate the kidney in this way. We have to palpate the kidney in the loin. Okay, it can be moved. This area is called as loin. Okay, so if you find any lump, it may be something like cancer. Normal kidneys, usually they are not palpable, but if you are finding any hard mass, it shows like there should be some pathology, like renal stones or cancer may be there. If there is any like road traffic accidents, there may be damage also to the kidney. So in the minor and major calyces, you are finding big stones. They are called as renal stones. Sometimes we may find a very big stone in the urinary bladder also. Okay, this was first identified, like this is the history, like Debrecen and all. Okay, suppose renal transplantation, in the sense, if you are taking some donor's kidney, if the like recipient's kidney is no more working, you will see, you will place that kidney in pelvic region, and the donor's renal vessels will be connected to the internal iliac artery. This will be receiving blood supply directly from the internal iliac artery. This is transplanted kidney. Okay, so I hope you understood kidney. So okay, so liver we did very recently, so we will see extrahepatic biliary apparatus. So the extrahepatic biliary apparatus, if you just look at the liver, liver has two lobes, right lobe and left lobe. From the right lobe, we will have right hepatic duct. From the left lobe, we will have left hepatic duct. The right and left hepatic ducts will join to form common hepatic duct. So this common hepatic duct will join this duct called as cystic duct. Basically, cystic duct comes from gallbladder. So right and left hepatic ducts will be generally synthesized, like the bile juice which is synthesized in the liver will be collected by these hepatic ducts, and it will be moving into the gallbladder. So from the gallbladder, you will see the bile juice will be entering into the cystic duct. So the cystic duct and the common bile duct will join to form the common bile duct. Okay, cystic duct and common hepatic duct will join to form common bile duct. So this common bile duct will enter into the second part of the duodenum. We will have other pictures also. Now when you just talk about this gallbladder, see, this is our gallbladder, which is seen on the inferior surface of the kidney. So this gallbladder, if you just see the cut section of gallbladder, it has fundus. Okay, it has body. This region is body, and then this is the neck of the gallbladder. From the neck of the gallbladder, you are finding this is our cystic duct. The mucosa inside the cystic duct will be showing fold. You call it as the spiral fold. Okay, we have right and left hepatic ducts joining to form common hepatic duct. The common hepatic duct is joining with this cystic duct to form common bile duct. So common bile duct, now you can see it is entering into the second part of the duodenum. This whole thing is duodenum. We know like common bile duct actually joins with the pancreatic duct to form hepatopancreatic ampulla of water. Okay, so gallbladder is storehouse for bile, and it has capacity around 50 ml. It lies in the fossa on the visceral surface of the liver, that is the inferior surface of the liver, and gallbladder is covered with peritoneum. Just now we have seen fundus, body, neck and cystic duct. So fundus is the blind end which projects beyond the lower margin of the liver. Body is upward continuation of the fundus. Neck is narrow part of the gallbladder, and cystic duct is a shaped continuation of the neck. Okay, so cystic duct is joining with the common hepatic duct to form common bile duct. So the common bile duct is 9 centimeters long, and if you just in my previous class also I told you this whole thing is the common bile duct. This thing, so this common bile duct, it has certain parts like above the first part of the duodenum, you call it as supraduodenal part. Behind the first part of the duodenum, you call it as retroduodenal part. Below the first part of the duodenum, you call it as infraduodenal part. And the one which is entering into the duodenum, you call it as intraduodenal part. I'm repeating the names. supraduodenal part, retroduodenal part, infraduodenal part, and intraduodenal part. These are the names given to the four parts of the common bile duct, which is around 9 centimeters long. Okay, so common bile duct. So supraduodenal part is seen in the free border of the lesser omentum, where we have hepatic artery at its left and portal vein is seen behind. Okay, then retroduodenal is the second part, no, which is seen behind the duodenum. Okay, behind the first part of the duodenum we see the retroduodenal. Infraduodenal part is actually entering within the substance of pancreas, and it will be moving towards the second part of the duodenum. So this part actually joins with the pancreatic duct to form hepatopancreatic ampulla of water, isn't it? So this is the common bile duct, this is the pancreatic duct. Both of them will join to form an ampulla, hepatopancreatic ampulla of water. Okay, it has all circular muscles surrounding it. You call it as sphincter. Okay, surrounding the common bile duct, you call it as sphincter of Colodicus. Okay, then surrounding the pancreatic duct, you call it as sphincter of Pancreaticus. Then together, hepatopancreatic ampulla of water, you call it as sphincter of Oddi, also called as hepatopancreatic sphincter. Okay, then. So common bile duct, see smooth muscle fibers surrounding the terminal part of the hepatopancreatic ampulla. There we have a sphincter called as sphincter of Oddi. When you see the second part of the duodenum, we have two openings. There is one minor duodenal papilla and the one is major duodenal papilla. Major duodenal papilla, you will have the opening of hepatopancreatic ampulla of water. Minor duodenal papilla will have the opening of accessory pancreatic duct. One day we can do pancreas as an essay. If you ask, I will take that question. Okay, because we didn't do pancreas as essay, no. So arterial supply, which artery comes? Cystic artery, which is a branch of right hepatic artery. Okay, venous drainage comes from portal vein. Lymphatic drainage of extrahepatic biliary apparatus, it drains into cystic nodes, hepatic nodes, and celiac nodes. Nerve supply, parasympathetic is vagus, sympathetic celiac plexus. Only this much you write. Parasympathetic vagus, sympathetic celiac plexus. Okay, clinical anatomy. Cholecystitis is the inflammation of gallbladder, and because if the like bile juice is not emptied into the abdomen, the bile juice becomes very much concentrated and it starts crystallizing to form stones. You call them as gallstones. There is a technique with the help of we do certain procedures for investigation and also treatment. You call it as, first this is cholecystography. Cholecystography is a technique where you will visualize the interior of the gallbladder. Okay, so I will tell you. So that is all about this beta. You can see cholelithiasis is gallstones. Generally, gallstones patient will have lot of pain. Okay, you can see the pain like gallstones may be anywhere in the fundus, in the body, in the neck, in the cystic duct, in the common bile duct, or at the level of ampulla also. Okay, all these are the areas where we may encounter the gallstones. Okay, so question may be framed. Basically, gallstones we find in people who are obese and usually above 40 years of age. Okay, so females, especially who have sedentary lifestyle, they are more at the risk of developing cholelithiasis, where patient will come to us with the abdominal pain, which is seen in the left lateral region of abdomen. Okay, so Vivek, is that fine?